Righty, so we have a couple minutes before the next session, so if you have any questions, come up to the microphone. I see a couple people moving. Go ahead.
Could you address the timing of the surgery for femoral neck fractures?
Okay.
There's been, many papers saying, the first 24 hours, other papers 48 hours. So that's one thing. Just a comment, when you fix a femoral neck fracture with percutaneous pins or whatever you're doing, you're making that person be non-weight bearing for upwards of a month or sometimes 6 weeks, which is a burden on the providers, the family, and society in general. So that may be a factor in deciding to go with a hemiarthroplasty or a total joint.
Correct. I would agree. I think most of us would agree. Joe, you want to take that first question?
Sure. Yeah, I think the data is pretty clear, and most of it is pertaining to the younger patients. 24 to 48 hours is ideal in the younger patient. I think most of us push it even quicker. Many of us in the past thought that a femoral neck fracture in a young person was an emergency, that we would take him to the operating room that night or certainly first thing in the morning. But the literature showed really no difference between 24 and 48 hours. In the older population, it's pretty clear that medical optimization, not clearance, but medical optimization influenced their outcome more than how quickly you got them into the operating room. So we have this hospital hip attack type program that is just about beds. It's really not about patient care. But that being said, we do try to maximally optimize these patients before getting them to the operating room. But when they hit the door, there's a greet time in the emergency room when the orthopedist is notified, anesthesia is notified, the medicine team is notified. But the bottom line is you don't rush those patients to the operating room until they're medically optimized. Cannulated screws are a problem because they're not a fixed angle device, and these patients can't toe touch weight bear, majority of these older patients. So the development of these fixed angle devices, that's why we went to the DHS and now the femoral neck system, I think has some advantages. They're fixed angles, they don't have to protect that hip. So if you're not gonna put an arthroplasty in, I would suggest you get familiar with a fixed angle device.
Yeah, so it used to be kind of the blood supply was a concern. If you're gonna fix them, you should do it right away, and doesn't seem to matter. So anyway, Utko?
Okay, so question for both Andy and Joe. So given that the longevity of the total hips get better and better in the last 2 decades or so, in a 55 to 60-year-old patient, otherwise healthy, displaced femoral neck fracture, what do you recommend if the patient asks you what you want to do?
So we actually do shared decision-making in these patients. We present
the patient asking you, what do you recommend?
Yeah, well, we are doing more and more totals in that complication because in that age group, and I'm older, I would be in that upper end of that age group now. You're going to be able to essentially maintain your normal lifestyle, whether that's sports, working. This is an age where people still are working typically. That's the group where you probably do want a really well done total, as opposed to say the 70 to 80 and older group where probably very few really would benefit from a total. So we are doing more and more in that age group, but we still do make sure we present both sides of the coin.
Yeah. So those are all important factors. What I've heard recently, and Andy pointed out that the trauma surgeon doing the total hip versus an arthroplastic surgeon doing a total hip. I'm not quite sure if all that's equal, the trauma surgeon and the arthroplasty surgeon, that's the factor that's influencing hip dislocations, for example. I think the hip dislocations are more because these patients come in with a normal hip and have just fractured their hip, as opposed to patients who have been struggling with osteoarthritis for 6, 9, 12 months, who come in a little stiff, a little cautious, a little bit more protective of that hip. I think that's influencing, for me, the dislocation rate more than who's doing the case.
There's actually data in the 55 to 70-year-old population showing that a total hip's better. There's a randomized controlled trial from Norway, 55 to 70-year-olds. Failure rate is 10 times higher with internal fixation. Functional outcomes are better with a with a total hip. And I would actually say the lower limit right now is 55. I wouldn't be surprised if it keeps dropping. The results with total hips are so good in young patients, and the data is very clear that doing internal fixation patients older than 55, like your complication rate is huge, and your outcomes are not as good.
Okay. Another question for you,
Who's
Emil.
doing the total hip?
What is your indication for a long nail for an IT fracture? So it seems to be like the trend is like short nails for all IT fractures. What is an indication to do a long nail or intermediate nail, whatever? Anything other than short nail in an IT fracture?
The only thing that I would use a long nail for would be a fracture that's distal enough that a long nail is not going to work, essentially.
Emil, in your study, did you just not see any thigh pain with the short nail?
It wasn't zero. We saw more negative outcomes with long nails. So we saw more surgical site infection, more fixation failure with long nails. Now, there may be some bias there, more complex fractures getting long nails, but even when we controlled for fracture factors and other factors, the odds ratio of an adverse event was 5 times higher with a long nail compared to a short nail. So, you know, there may be some uncontrolled bias that's still driving those results, but even when you look at it like statistically, like there's clearly no advantage to using a long nail. Best case scenario, it's maybe neutral, but the data would suggest that long is actually not as good as short.
Yeah, and it's my senility, but when I read that paper a long time ago, I didn't think you talked about thigh pain. Did you? And I just missed it? Or
now, this is actually a recent trial that we've done. So we just published the primary trial in JAMA. Okay. So it's like published like last year. Okay. And we're just looking at the 850 patients, the 425 that got a nail. We did a sub-study on those patients, and in that 425 patient group, a short nail outperformed a long.
No, I understand that, but did you ask for the thigh pain in the short nail? Okay, yeah. And you just didn't see much. All right.
So can you clarify this extension? How distal extension of the fracture will make you objectively, like 5 centimeters, 2 centimeters below the lesser trunk, will make you convert to a longer nail?
It would be fairly distal, like 5 centimeters and more. Like, so something that's in 2 or 3 centimeters from the lesser, I just use a short nail.
I was going to make a comment about long nail. We've seen patients who, as we age, the 80, 85-year-old group who has a metastatic disease below a small nail. So in that group, we've had a tendency to use longer nails. So that might be a consideration for very rare indication for intermedullary nailing, long versus short.
Yeah, I mean, I think there's always going to be exceptions. Yeah. But I mean, I think for the average patient that has an intertrochanteric fracture that you're going to use a nail, a short nail works just fine. It's way quicker. There's less blood loss. It's cheaper. Like, it makes a lot of sense to use a short nail. And there may be some, you know, extenuating circumstances like what was just described. You're worried about cancer, maybe a more distal fracture pattern, but there's been a lot of stuff looking at, you know, like you got a very unstable fracture pattern, you have a capacious canal, you need to use a long nail for better stability. None of that's ever been borne out clinically.
Yeah. Did you have a question?
Yeah, I have two. Emil Ewald, faculty. Thank you guys for an amazing session. Emil, I always enjoy your presentations. You covered intertroch so well, but there's one thing which I would like to know better. Do you find difference between the screw and the blade plate design of the intertrochanteric fixation? You didn't kind of address this difference, if there is. I personally stopped using screw for the last probably 10 years and using only a blade plate for my intertrochs. So this is the first question.
I mean, I typically use a screw. So I've been a kind of gamma nail user, so I use that particular implant. I don't have a lot of experience with other devices. I know if you look at the literature, there's no evidence that suggests one method of fixation is better than another. So, for example, you know, integrated screws, there's been a lot of biomechanical evidence suggesting that those, for example, are better. If you look at some clinical studies, they show maybe they're better. There's just a study that came out in the JBJS from Norwegian Fracture Registry, showing that an integrated design like Intertan for actually was outperformed by like a gamma nail. So I think it's really controversial in terms of proximal fixation. What is the ideal fixation? I would say right now we don't know. So I don't think there's one device that stands out that is better than any other device. There's no clinical evidence for that.
I think we're losing the art form of using the blade plate. I mean,
They tried to stop making it, and
Yeah,
then there was such an
know.
uprising.
My
Talking
second
blade, like
I'm talking about
Spiral blade.
Spiral blade.
Yeah, that's
not an old blade.
right, and that's basically what my comments were talking about.
I
There's
got
not a lot of good clinical evidence that shows there's any difference between dual screws, a single screw, or a spiral blade.
So I saw in one of your case you had 2 screws. Is there a thing that tells you that you should use 2 screws instead of 1?
Yeah, I mean, that case is, I would say that was more of a subtrochanteric fracture. So in a subtrochanteric fracture, I'll often use 2 screws.
Yeah.
But for a typical intertrochanteric fracture, I would use a single screw typically.
Okay.
And the second question is, nobody talks about it, but I always think about it when I do my intertrochs. 4 parts, greater trochanter fracture. Do you guys address this issue? Because none of our tools really has it. And we all know there is 4th part, which is greater troch, which often is kind of displaced and whatnot. Can you elaborate on the subject, the significance of reduction and fixation of the greater trochanter?
I mean, I think most of the time when you're doing your reduction, the troch comes with it. I mean, if it's a free fragment, then I'll bring it down and hold it with a plate, like a separate plate. But most of the time, you can fix the fracture just using a simple implant. Like you're not having the trochanter way up and off. I mean, that usually is a unit. You do your reduction, and then you can just fix it with whatever implant that you're going to use, a sliding hip screw or an intramedullary hip screw, usually not having to use some sort of secondary fixation. But if secondary fixation is required, then I would use a separate plate, like a hook plate.
All right, we're going to move on. Unfortunately, most of the time those greater troch, there's enough soft tissue. But any other questions, the faculty will be around and you can talk to them. And we're going to turn it over to Andrew for the next section.